A low arousal approach can be defined as the least aversive way of managing behaviour.
This film explains the philosophy of low arousal. This fits within a cognitive behavioural framework. How we think and how we feel affects how we behave.
You okay? I'm appetite.
I'm so excited about it.
These people have many things in common.
He's a lovely boy.
Their needs are such that from time to time they may require care or support from others in order to live. A small percentage of people may become disturbed, upset, frightened or angry.
I thought you were my friend.
Paul?
These situations need to be handled sensitively.
Maybe she's got a sore throat.
How do we react when we are upset or angry?
Oh, bugger it.
It is normal for most of us to become upset or to lose it from time to time. Statistics claim that some people lose their tempers on a daily basis.
When we are upset, how do we wish to be treated? What calms us down? Now think of the people we work with. Supporting them presents a challenge to us. How do you manage these behaviours protecting them and those around them?
What winds people up? There are many causes of frustration and anger, some of which we can identify with and understand. Others relate to unseen patterns of mental health. The more factors that combine, the more likely it is that we become upset and find difficulty controlling our emotions. This is true for us as individuals or as carers, and is also true of the people that we provide services for. Therefore, we can conclude that in the right circumstances, we are all capable of losing it.
While we understand this, we must also be aware that if a bad attitude prevails, staff may find themselves accused of abuse.
The law and policy may not always be helpful. While staff must be aware of the law and policy, the phrase assault and reasonable force may not be commonly associated with the care or the caring services. However, we have a duty of care to protect vulnerable people. Legislation on human rights demands that these situations should be managed effectively, with dignity, using trained staff. This is a major challenge to carers and staff. Merely attempting to strike or threaten an individual can constitute assault. Touching an individual without their consent can be considered assault and battery. The law will examine the act and the intent in order to decide reasonable force. Therefore, there is no definitive definition of the term reasonable force. The Human Rights Act 1998 requires that public authorities and all who work in them will have to check that they do not ride roughshod over the rights of any person, even when they believe that they are doing so for a good reason. The Convention rights include Article 3. You have the right not to be tortured or subjected to inhumane or degrading treatment or punishment. Article 5. You have the right not to be deprived of your liberty except in limited cases specified in the article and where this is justified by clear legal procedure. How many things do we do on a daily basis that may be interpreted as punishment? In trying to understand what winds people up, you must be aware of what calms people down. Being treated with respect despite the anger and being taken seriously. Being given attention and listened to and talked to gently. Allowing our circumstances to be taken into consideration. And being allowed to have a bad day.
The sorts of behavioural challenges that we face vary considerably from the sorts of challenges that you might have because of physical difficulties, incontinence being one of them, right the way through to aggressive behaviour, non-compliance, some forms of sexual inappropriateness and so forth.
We did some research on the inpatient wards where I worked, and what we found there was that the actual violence which occurred tended not to be too sophisticated. People punched or slapped, shoved or pushed, and very rare. And they were the two main categories of assault.
I guess we meet all the usual challenges, certainly violent and aggressive behaviours, self-injury, and a range of other behaviours which actually make it difficult for the person to fit into a community.
And really depends upon what people see as a problem. In my experience, it has been that if a staff team or a family or someone caring for an individual finds something difficult, then that's a problem and that's a challenge.
The common situations I face are other patients invading others' personal space, wandering, sometimes with an unsteady gait, so you've got the risk of falling. Because they are confused, they might attempt to leave the ward, and then you've got the risk of getting lost.
I mean, some behaviours that we're dealing with tend to be very frequent indeed. So you might be talking about attacks on staff on a regular basis, half a dozen times even during a day.
Research shows that in behaviour challenges, that verbal behaviours or behaviours that are about demands made upon people happen a lot more often than physically aggressive behaviours or self-injurious behaviours.
Frequency is really difficult to sum up. You could go for weeks and weeks without having any kind of confrontation with anybody at all, and then what tends to happen is that there's this domino effect. One person tries to leave, it leads to confrontation, somebody else picks up on that kind of vibe that's going around, and it tends to have a knock-on effect.
The level of problems that you'll get obviously will vary. In continuing care provisions, particularly within mental health, you're likely to get a lot more behavioural difficulties than you would, say, in residential care or in nursing care homes. And that's largely because the type of people that tend to be referred to continuing care are those people who may be experiencing significant mental health difficulties, dementia, and behavioural difficulties as a result. Indeed, that's one of the criteria which tends to select people, whether they go into nursing care or whether they go into psychiatric continuing care provision.
The question we often face is why? What is happening to cause these behaviours? What part do we play? To address these issues, we have to look for tools to help us.
What are the common causes of aggression? Pain, fear, misunderstanding, confusion, being ignored, needing to be heard. The only way to understand is to directly observe these behaviours. This enables a plan to manage the behaviours to be developed. Plan should be non-aversive. This essentially means focusing on preventing the behaviours from happening and avoiding confrontation. What do we mean by this term?
I think low arousal is an integral part of all our approaches. It's essential, it's fundamental to what we do.
I was initially very sceptical in lots of ways because I was very much of I am the nurse in charge. I must always be in charge. I must always be in control of the situation. And I found it very threatening personally, the whole idea of low arousal.
My first contact with the philosophy of low arousal was when I bought into a service, Studio 3 training. What I looked for in training was not just a physical management that was gentle and that was easily learnt, but also that was value-based and had a good philosophy.
How does low arousal theory change the way we view a person's behaviour? This is an observation exercise. Watch the role play and record what is happening. What we believe about person A and person B affects how we view their behaviour. By observing behaviour, it increases our understanding and knowledge of the individual. Being aware of what influences our perception, or what we believe about the behaviour, may alter our attitude.
Recent research suggests that perception of behaviour affects how behaviour is managed. For example, if we believe that somebody is being deliberately difficult, we may personalise the behaviour. If we think that the person is not in control of their behaviour, staff may perceive this differently and be more tolerant.
He's later on.
Another factor shown by research to affect how we cope with situations is tolerance.
Tell you what, do you want to come and sit down for a minute?
This does not measure good or bad staff, but the interrelationship between what we find difficult to cope with, such as behaviour presented by the person. For example, one member of staff may find persistent questioning annoying, where another copes badly with people who shout or threaten. Staff may be more patient at the start of a shift than at the end of it.
When Mum and Dad come in. When Mum and Dad come in.
How behaviour affects people varies from person to person, and therefore from team to team.
Understanding of arousal in people is essential when managing situations. Most people who challenge are highly aroused at the time. Therefore, we should avoid doing things that will further arouse a person. Just like throwing a stone in a pond will result in ripples, so the emotion following an incident will continue until a calm atmosphere prevails.
Behaviour occurs in the context of powerful emotions. For example, anxiety, anger, craving. These make demands upon our central nervous system to fight or flee, to get our needs or wants met, or to have our say on injustice. A large proportion of challenging behaviours are preceded by a demand or a request. As we react to situations, our arousal level rises, slowly at first, and then steeply. This will result in a set of behaviours that have been learned or evolved in order to vent our feelings. They avoid a demand, allow us to get our way, or fulfill a need. Arousal is best illustrated by looking at the arousal curve. To understand arousal, we plot a graph of arousal level over time. The arousal curve increases due to stimulation. As time passes, the arousal curve varies with the normal range of arousal. If demands are made on a person, this may move the curve into a trigger zone. This area may indicate the potential for an incident to occur. Further demand can therefore result in behaviour or an incident. The trigger zone needs to be managed very carefully to avoid incidents. Watch the following incident. What is arousing? What is not helpful?
Oh, calm down now, Steve. Dad likes music. No one living in this house. Turn the music off. Calm down. Calm down. Calm down. Calm down.
Stephen is already highly aroused. The member of staff turning on the music upsets him more, and a struggle ensues. At the top of the arousal curve, we see the incident. When someone has lost it, it is extremely difficult to handle, even with good training. As the incident progresses, the person should calm, and the arousal curve gradually return to normal. However, to return to normal, the curve passes again through the trigger zone. This means the danger of another incident, until the person is truly calm and returns to the normal range. Let's observe another incident.
Where are my slippers? I say, where are my slippers?
They're on your feet.
No, Mrs. James has stolen them.
Mrs. James is dead.
No, she's not. She's stolen my slippers. Oh, don't she step them? Where are my slippers?
Mary is confused, but the staff member is distracted and fails to recognise that Mary is becoming upset.
No, Mrs. James has stolen them.
Mrs. James is dead.
No, she's not. She's stolen my slippers. Oh, don't she step them? Where are my slippers? I say, where are my slippers?
Mary, you're wearing them.
No. Mrs. James has stolen them.
Should we go to your room and have a look for them?
Oh, all right.
The member of staff is now approaching Mary more sensitively. She redirects Mary's attention to looking in her room and avoids frustrating or confusing her further. These incidents clearly show the rising emotion, the arousal level, and the resulting behaviour. Eventually, the arousal level will fall again, and then return to normal levels. But the incident will be remembered and may damage the relationships between those involved. Now let us apply the principles of low arousal. Di has a mental health problem. He enjoys singing, but can become very intense and demanding.
Pete, can I sing you a song?
Oh no, Di, I'm doing the medication.
Oh, let me sing a song. I've got a good voice. In Dublin's fair city.
Stick your medication.
Where the girls
Medication,
are so pretty. Get me on Channel 4.
Don't be silly. After you've taken your meds.
Oh, please get me on Channel 4.
Who'd think I am?
Oh, bugger you.
Sometimes we have to ask people to do things, but how we make the request is important.
Pete, can I sing you a song?
Oh no, Di, I'm doing the medication.
Oh, let me sing a song. I've got a good voice. In Dublin's fair city.
Stick your medication.
Where the girls
Medication,
are so pretty. Get me on Channel 4.
Don't be silly. After you've taken your meds.
Oh, please get me on Channel 4.
Who'd think I am?
Oh, bugger you.
Can we make some requests that are preferred by the client and then add the negative request at the end?
Sing us a song, Di, and then you can take your medication.
Oh, certainly, Pete. In Dublin's fair city, where the girls are so pretty, I first set my eyes on sweet Molly Malone. Yeah.
It's marvellous, Di. Here's your tablet.
Psychologists call this behavioural momentum. Do we need to make the request at all? Can we bargain with the individual? Can we divert the person naturally? Many people tend to rebel against authority. I think we all respond better if people are nice to us.
Planning is essential to prevent situations occurring. We can do this by getting to know the person well, reviewing their past history, recording and analysing situations, knowing their likes and dislikes. From this, we should know what the cues are that precede an incident, and also what is likely to trigger an incident. This should lead us to formulate a plan to distract the person or to calm them down. This plan should minimise incidents. We call these reactive plans. It is essential to try to prevent incidents occurring. It is not realistic to totally avoid them.
Action. Hi, Paul. Hi, Gerald.
Yeah.
I've got those pictures to show you.
Yeah.
Yeah?
Hi, Claire.
Hi.
Fag.
No, you just had one.
I'm fag. I got
Social worker coming.
I know.
happen? I
No,
need-
you just had one. You don't need another one.
I need a fag, though. I need a fag.
But you're going to run out.
I'm worried. I need a fag. Please. I
No,
need
me
a
and
fag.
Gerald, don't worry about it,
I need a
Paul.
fag.
No, you don't need a fag.
I need a fag. I do.
You don't need a fag.
I need a fag.
You're going to run out.
I need a fag.
Paul, I'm just showing Gerald the pictures.
I need a fag, Claire, please.
I don't think you need a fag,
Please.
Paul. Calm down, Paul. You don't need a fag.
Please, I need a fag. Please. I need a fag.
Gerald?
Yeah.
Who is it that's going on holiday?
I need a fag.
Can you show me who's going on holiday?
I thought you were my friend.
Paul?
That's bad behaviour.
Yes.
Bad behaviour.
Bad behaviour.
Bad, Paul, bad.
Okay. Not to worry. Not to
No.
worry. Not to worry.
Paul's a fag.
Yeah. Hi, Paul. Hi, Gerald.
Yeah.
I've got those pictures to show you.
Yeah.
Yeah?
Hi, Claire.
Hi.
Fag.
No, you just had one.
The member of staff has not recognised how anxious Paul is about the visit of his social worker.
No, you just
Paul
had
becomes
one.
increasingly upset at being ignored and not getting his cigarette.
I need a fag.
But you're going to run out.
I'm worried. I need a fag. Please. I
No,
need
me
a
and
fag.
Gerald, don't worry about it,
I need a
Paul.
fag.
No, you don't need a fag.
I need a fag. I do.
You don't need a fag.
I need a
You're
fag.
going to run out.
I need a fag.
Paul, I'm just showing Gerald the pictures.
I need a fag, Claire, please.
I don't think you need a fag,
Please.
Paul. Calm down, Paul. You don't need a fag.
Please, I need a fag. Please. I need a fag.
Gerald?
Yeah.
Who is it that's going on
I
holiday?
need a fag.
Can you show me who's going on holiday?
I thought you were my friend.
Paul?
That's bad behaviour.
Yes.
Bad behaviour.
Bad behaviour.
Bad, Paul, bad.
Okay. Not to worry. Not to
No.
worry. Not to worry.
Paul's a fag.
Yeah. Hi, Paul.
Hi, Claire.
Hi, Gerald.
Yeah.
Hi. Look
Claire,
what I've got.
I need a fag.
Pardon?
I need a fag.
Okay, not to worry.
I need a fag. I'm worried.
Okay, what are you worried about?
A social worker coming.
You're worried, are you, Paul?
Yeah.
Okay. I tell you what, Paul. Gerald and I are going to look at these pictures. Give me a moment, then we'll go outside and have a nice cup of tea and a fag.
Yeah.
Is that good?
Yeah.
The member of staff is now responding to the plan that indicates that Paul will become worried when having a visit and will bite his nails when anxious. Therefore, she responds appropriately. Low arousal theory means looking at any limits and questioning if they are justified, finding ways to reduce demand, and distracting the person that is upset.
Some staff feel that low arousal is about reinforcing bad behaviour. In my experience, that was a genuine concern that had to be addressed. But in practice, and I think now in terms of research, we know that reinforcing to avoid a large incident, using a reward to avoid something happening, doesn't mean that behaviour will constantly reoccur.
What is the best way to manage incidents when a person becomes very upset or even aggressive? The essential components in managing situations are recognizing and managing the emotions, staying calm and pretending if you're not, keeping a safe distance, and removing others if possible. You must be aware of eye contact, not staring and not touching, and you must know the person. Listen to the person and speak gently to them. Distract by changing the focus of attention. Record the incident and debrief.
Yeah, Steve. Oh, jeez. I need a chat. I feel absolutely awful.
Oh, what happened?
Oh, Tony hit me.
He hit you?
Out of the blue. I feel lousy.
There are many things to remember during an incident. People will need training in coping. Many blank or forget what they have learned. This can be overcome by follow-up support and counselling. What support do we require following an upsetting incident. What is debriefing? It is reassurance and help with coping. It is supporting the individual to learn from the incident. A debriefing plan should outline who the person should talk to immediately following an incident and should be discussed at the person's next supervision session. It must also outline, where necessary, what outside counselling is available. Debriefing should listen to and reassure the person and help them to cope. It should also identify any further counselling and training that is required. Debriefing should help us learn from past incidents. Low arousal theory must include good staff support to enable it to work effectively.
Low arousal philosophy gives us an approach in managing situations when people are upset. These are powerful emotions. This approach helps to calm people and avoid a severe incident, protecting us all.
We're supposed to take into account somebody's distress, what somebody's needs are, and try and reassure them, try and meet their needs as far as possible.
Low arousal theory enables us to create a culture for caring together.
On the ward where I work, we are committed to using a low arousal technique, and we have found that it has reduced incidents of challenging situations. And I think with the training, it has heightened nurses' awareness of the need to use low arousal technique.
You know, what does it matter if you put the tea out half an hour early and give someone a cup of tea? It's not losing my power base, it's not losing my control of the situation. It just means that I'm not going to be nose to nose with somebody shouting and screaming at me because I won't give them a cup of tea.
It is very much a non-threatening approach, and there is also a reduction of demands and unnecessary rules.
It was only through sort of like learning that it wasn't threatening, that it was basically what I was trained to do anyway, to listen to what somebody's needs are and to try and meet them as far as possible, as soon as possible. And what I found was that by adopting that kind of procedure, that kind of policy within my own practice, that it lowered the confrontation that I used to have between myself and clients.
Low arousal would be the way in which the staff actually deal with the client on an hour-to-hour basis, a way of avoiding confrontations, a way of trying to meet needs, and a way of making sure that people actually are empowered within their situation.
Somebody wants to go for a walk, find a way to let them. Find a way to help them. If it's going to lower their responses, it's going to lower their arousal to it, then find a way to try and get around it. And it just makes things run an awful lot smoother. And you're not losing control of a situation. You lose control of a situation when somebody's verbal and physical response to what you say to them becomes unmanageable.
Low arousal to me was the way forward because it emphasised distracting from situations. It emphasised managing people in a kind and gentle way. It emphasised trying to plan to avoid the problem. So the whole theory fitted in very well with the philosophy of our organisation.